It's 7:30, so I will get started. So good morning, everybody. Thank you for joining us for Grand Rounds today. We are delighted to be able to have Dr. Ellenbogen give our Grand Rounds this morning. I'm sure everybody on the call knows Dr. Ellenbogen very well, but for those who don't, he is Pauley Heart Center's Director of Clinical Cardiac Electrophysiology and Pacing on the MCV campus. He has held the Kimmerling Professorship in Cardiology since 2018. He is a fellow of the American College of Cardiology, the American Heart Association, and the Heart Rhythm Society. He is a member of the Council on Clinical Cardiology and the Council on Circulation of the American Heart Association. He served as chair of the American Heart Association's Committee on Electrocardiography and Arrhythmias, the Education Committee of the Heart Rhythm Society, and served on the Board of Trustees for the Heart Rhythm Society. He has received the Outstanding Teacher Award from the Heart Rhythm Society and Outstanding Mentor Award from the VCU School of Medicine. Dr. Ellenbogen is the editor or co-editor of 5 textbooks of cardiac electrophysiology and pacing. He's presented over 300 abstracts at major scientific meetings and over 415 peer-reviewed manuscripts and more than 21 books and monographs. Dr. Ellenbogen serves on the editorial boards of the Journal of the American College of Cardiology, American Heart Journal, Circulation, Journal of Cardiac Electrophysiology, Heart Rhythm, Europace, and as a senior editor of Heart Rhythm. Dr. Ellenbogen has been an invited lecturer and speaker all over the world and has given over 350 talks at major national meetings, including lectures at some of our finest institutions: Harvard, UCLA, Yale, University of Michigan, University of Virginia, Cleveland Clinic, and George Washington University, to name a few. Dr. Ellenbogen was a member of the writing committee for the multi-society guidelines for atrial fibrillation, implantation of cardiac rhythm devices, and mode selection for pacemakers, programming of defibrillators, and the guidelines for left atrial appendage occlusion devices. He was also the program chair for Heart Rhythm Society meeting in 2023 and president-elect to the Heart Rhythm Society. So without further ado, I will turn it over to Dr. Ellenbogen, who is going to be speaking on a really exciting topic. And as always, there's the CME credit code for those who wish to use it.
Hey, thank you very much, Jeff. And I want to take this opportunity not only to give cardiology grand rounds, which I haven't done for a period of time, so it's great to be able to find the time to do it again, but to wish everyone a very happy and healthy holiday with their family. So I'm going to talk about ventricular fibrillation and all the amazing things we can do for those patients in the electrophysiology lab. This is the code once again for SAMI credit. And these are my relevant disclosures or disclosure relevant to the talk I'm giving today. So let's start off with the case. This is a young patient with polymorphic ventricular tachycardia. We see patients like this every several months. This particular patient got 30 external shocks in 24 hours, despite aggressive electrolyte replacement, deep sedation, IV amiodarone, and IV lidocaine. Obviously, electrophysiology is called. This is just several strips from the patient's monitor. You see bursts of what looks like ventricular fibrillation, followed by periods of sinus rhythm with bursts of ventricular fibrillation. This patient is obviously critically ill in the ICU. What are you going to do next? Well, one of the things you first want to do is make sure it really is ventricular fibrillation. So you look carefully at the EKG and the telemetry. You want to make sure the patient is not having artifact. We see this not uncommonly. A patient had a short episode of VF, and it's in fact artifact. A lead is loose. And of course, you want to make sure, particularly in a young patient, they're not having pre-excited AFib or AFib with conduction over an accessory pathway. But this is the real deal. The patient has gotten multiple shocks. And here's this same patient, 12 lead EKG. What is the diagnosis? What do you see here? You see sinus rhythm in IVCD and frequent PVCs. But you also see a very, very prolonged QT interval. This prolonged QTC and these PVCs, which are probably being triggered by EADs or early after depolarizations from the ventricle. Now, in this particular patient, our strategy was for recurrent VF with a markedly prolonged QT was to do something that changed the autonomic nervous system. And there are a number of maneuvers that one could perform to change the autonomic nervous system or to change the tone of the autonomic nervous system. They include stimulation of the vagus nerve. They include stellate ganglionic blockade, and you can do that temporarily or permanently. They include GP ablation on the epicardial surface of the atria or ventricles. They include pharmacologic interventions, not yet very practical, injecting botulinum toxin or calcium chloride into the ganglionic plexi on the outside part of the heart. Easy to do when you have open heart surgery, hard to do when you have a patient fibrillating in the ICU, and renal sympathetic denervation. And I won't talk very much about this today, but it is something we're interested in doing and planning on doing in the future for patients with persistent AF. In this particular case, we performed stellate ganglion blockade, and you can see the relevant landmarks, the relevant anatomic landmarks. See the thyroid, the cricothyroid process. You see the angle of the needle. There are several different ways to do this blockade. We do it largely using ultrasound. This is a paper Jay Conneru wrote a number of years ago where he described our technique in a small number of patients, as well as the excellent results we got with stellate ganglion blockade, with the main concern obviously being the carotid artery. This is the muscle. These are the landmarks. A number of us have learned how to do this from the uh, pain anesthesiologist, but you can easily do this and get temporary or transient stellate ganglion blockade for 24 to 48 hours and get some idea how the patient may respond long term. Permanent ganglionic blockade involves a minimally invasive thoracoscopic approach. We have a number of thoracic surgeons who do a very good job at doing this. And it involves, as I said, a small thoracoscopic incision. We always ask our surgeons to do bilateral cardiac sympathetic denervation or bilateral cardiac sympathetic ganglionic blockade. And what they do is they destroy the cell bodies from T1 to D4 to remove cardiac sympathetic innervation of the heart. So here's the EKG following temporary stellate ganglionic blockade, which one of our attendings did. You notice that the QT interval, the corrected QT interval is still markedly prolonged, but it's had a tremendous effect on the patient's episodes of ventricular fibrillation. Here is a study published in JAHA, which includes probably the largest numbers of patients from a single center to have bilateral cardiac sympathetic denervation. And you can see in this series, patients had VT ablation, and the VT recurrence rate was 3.43. So still having a lot of VT. They then go for cardiac sympathetic denervation. They would be predicted to have a VT recurrence rate of 5.61. And in fact, the incidence of recurrent VT was decreased dramatically to 3.58. And here you see it in terms of a Kaplan-Meier survival curve out to at least 12 months for these patients. This is the expected rate of VT or VF recurrence up to 50% at 1 year, and the observed rate of recurrence at 1 year is closer to about 15 to 20%. This is another study, fewer patients, 20 patients, but the take-home message is with bilateral cardiac sympathetic denervation, you not only decrease the incidence of polymorphic ventricular tachycardia, but you increase the incidence of monomorphic ventricular tachycardia. And that was found in some people with ischemic heart disease, but in many, many patients with non-ischemic heart disease. So let's go back to our patient. The patient went from having long-acting anesthetics injected into the stellate ganglion, into the back of their neck to get stellate ganglionic blockade to permanent stellate ganglionic blockade, done on 8/24 at 6 a.m. And then you can see after that, the patient just completely stopped having PVCs or VT thereafter. So no more shocks, no more polymorphic VT. The patient did well, was discharged home after, about 2 to 3 days after permanent cardiac sympathetic blockade and did exceptionally well. Now, let's talk about another patient. This is a 42-year-old gentleman with a BMI of 43, a non-ischemic cardiomyopathy, EF of 30%, who had VF storm at another institution. He had 20 or 30 ICD shocks. He was placed on sotalol, was on mexiletine, continued to have shocks, and was transferred to our ICU for endocardial plus epicardial ablation. And this is the patient's electrocardiogram on presentation. You can see sinus rhythm with a PVC here, sinus rhythm with a different morphology of PVC seen here. So you see the patient has two PVCs, a left bundle morphology PVC, QS and V1, and a right bundle morphology PVCs. The patient was referred for both endo and epicardial ablation, but you see because the PVCs are relatively narrow, about 120 to 130 milliseconds, and in each lead they have a rapid downstroke, they're likely to be coming from the Purkinje system or the septum, unlikely, rarely, to be coming from the epicardium. This is an ICE image, intracardiac echo image of the patient's LV cavity. See, the patient has a very small LV cavity. Here's another image. You see there's some fat at the base of the heart, but this patient, not only does his heart not beat particularly well, but he has a very, very thick heart. So clearly the patient was sent here for an ablation. He had multiple shocks in the ICU over the weekend. So Monday morning came and the ICU was quite glad to have the patient in the EP lab. And you see morphology PVC number 1, PVC number 2, PVC number 3, and PVC number 4, and yes, PVC number 5. So this is a typical appearance for PVCs that induce VF in the sense that we worry more about PVCs that are shortly coupled, that are very closely coupled to the preceding R wave and land on the preceding T waves. Pleomorphic PVCs like this, at first glance, would be very concerning for a very long day in the EP lab. But pleomorphic PVCs like this that are relatively narrow are highly suspicious for PVCs coming from the septum, and in particular PVCs coming from the conduction system. You'll hear more from me about that as we discuss this case further. Again, we always worry about short coupled PVCs. They're far more likely to trigger VF or polymorphic VT, and you can see in this case, this recording from the EP lab with a 12-lead electrocardiogram shown on the left in classic format. You can see a short coupled PVC. Here it's a 375 millisecond coupling interval, followed by 2 beats of ventricular tachycardia. Note, they're not monomorphic. It's quite polymorphic in appearance. And let me just orient you. This is RAO, LAO. These are fluoroscopic images. This particular image is elegant, the LAO image, because the interventricular septum comes down here at an angle. How do we know that? Well, you can see intracardiac echo. You can see here a catheter on the RV side of the septum. Here you see the ICD lead and a catheter on the left ventricular side of the septum. So the septum's in between here. Here's the RV side of the septum. Here's the LV side of the septum. Here's the RAO image. We have multiple catheters that can record multiple electrical signals. We're on the interventricular septum, so we're capable of recording signals from the conduction system of the heart, because as you know, the His-Purkinje system lies in the interventricular septum. So we have a decapolar catheter along the RV septum and a decapolar catheter along the LV septum. LV septum, RV septum. So in the EP lab now, we're recording from the 12-lead electrocardiogram and from the decapolar catheter. Decapolar just means it has 10 bipolar electrodes. You see a sinus rhythm beat here with the His-Purkinje system being activated from the top to the bottom, from the top to the bottom. Then you see two PVCs here. They have multiple different morphologies. Please note carefully. This PVC looks different from that PVC. But what do you see? You see a reverse sequence of activation of the His-Purkinje system. And here you see a split potential on the His-Purkinje system, indicating abnormal conduction in the His-Purkinje system. Furthermore, this electrical activation during the PVCs, again, normal from top to bottom electrical activation of the conduction system. Now we're bottoms up electrical activation of the conduction system with a PVC. And these electrical signals are quite early, approximately 35 to 65 milliseconds, telling us this is probably a great area to investigate further. And this is just another example of yet a different PVC and even earlier activation of the conduction system, again, bottoms up or in the retrograde or abnormal direction. So back in the EP lab, the patient is having paroxysms of non-sustained ventricular fibrillation. And you can see normal electrical activation of the His-Purkinje system. And with these abnormal beats, with this run of polymorphic ventricular tachycardia, you have activation of the His-Purkinje system in the reverse or abnormal direction for every single beat. So going further, and this is just enhanced so you can appreciate what typically is a sharp electrical potential, now all messed up, wide, indicating slow and abnormal conduction in that area. This is what it's like in the EP lab. When you study somebody with ventricular fibrillation, you see ventricular fibrillation. And what you need to do is be able to understand the activation in the first second with the first beat of VF. Now, in this patient, the ablation catheter is at a good site. Before the ablation, the patient already went into VF storm in the EP lab. The patient had 11 shocks at 360 joules in quick succession. He got lidocaine, amiodarone in the EP lab. The patient continued to have episodes of VF, multiple episodes of VF, some sustained, some not sustained, and multiple shocks. Here's a shock here. You see the patient has PVCs, PVCs, now a different PVC, a different PVC, a different PVC, and then a PVC triggering VF again. Multiple shocks in the EP lab, and again, and again, and again, and again. 11 shocks in 3 minutes, and then VF becomes dormant. VF becomes dormant, sustained VF, but still we're having short bursts of non-sustained VF with this highly abnormal electrical activation here. This is a computerized 3D reconstruction of the heart. This is the left ventricle here. This is the RAO view. This is the LAO view. And you can see the area of interest. This area of interest corresponds to the left anterior fascicle. You can see there are multiple ablation lesions delivered along the septum. Sorry. You can see during delivery of radiofrequency ablation in this area, it's not uncommon. I'm sorry. It's not uncommon to see automaticity, that is, short bursts of electrical activity from that area. Notice they're monomorphic, not polymorphic. The heat energy from the tip of the RF catheter is heating up the conduction system. The Purkinje network is part of this conduction system. So the heat causes automaticity in that area. So you get firing of the His-Purkinje system. So that's the map of the distal left fascicle. That's what happens during ablation. This map shows you the initial set of lesions, small number of lesions, 10 or 12 lesions, that to orient you again. Here's the His bundle. Everyone knows where the His bundle is located, and the interventricular septum, right? So by the non-coronary cusp, so it's high up here, you see we're on the septum. You can easily see we're on the septum in LAO, because in LAO, the septum's looking at us en face. This black thing here is the interventricular septum. Here's the RV, LV. You can see the His bundle on the interventricular septum, and many of these lesions in the mid-interventricular septum. So half normal saline to get bigger lesions. Two lesions at 45 watts resulted in what's called steam pops, micro bubbles, but it's in the septum. 35 to 40 watt lesions, big impedance drops, able to see the lesions on ice, on intracardiac echo. Post radiofrequency ablation, no more PVCs. So these are where the highly extensive number of lesions. And then what happens to this patient? 1 month later, quinidine is discontinued. Now, several years after this case, the patient has never had another episode of VF. He obviously still has his defibrillator, but this is a success story. And there are many similar success stories. Here's another patient. This particular patient is also a young man. He was having pre-syncope. He had multiple episodes of non-sustained polymorphic ventricular tachycardia. Multiple episodes, and you can see these short bursts here. They look ugly, they look malignant. How do I know they're malignant? Because once again, the PVCs are early coupled to the preceding beat. You see the patient goes on to have short bursts of non-sustained polymorphic VT, then longer bursts of non-sustained polymorphic VT, even one or two that required cardioversion. Now, this particular PVC that triggered VF was coming from the moderator band. This is, I'll show you what it looks like. This patient required a number of radiofrequency lesions on the moderator band. And in some cases, we have had to resort to cryo just because the moderator band is a thick muscle. And to get a deep enough lesion, we've had to cryo using an 8 mm cryo tip. But you can see the moderator band here attaching to the RV papillary muscle, the right ventricular papillary muscle. Again, you can see where it's located in the LAO view relative to the septum. Now, this is a picture of a moderator band from a cadaver. Here's the papillary muscle. You can see it attaches from the septum, from the RV septum to the papillary muscle. I bet the fellows remember from our EKG thing on Tuesday that the first person to describe the moderator band was the famous anatomist and great polymath Leonardo da Vinci hundreds of years ago. This is a moderator band. You can see they're nice. Now, I want to talk a little bit about ventricular fibrillation because as fascinating as those cases are, the interesting thing is that the His-Purkinje system is enemy number one, is integral in triggering and sustaining ventricular fibrillation. In a series of patients, a large number of patients, the His-Purkinje system, both on the RV side, and the LV side in particular, occasionally both. So almost 60% of episodes of VF came from the His-Purkinje system. And here's what's fascinating. This is true whether the patient has idiopathic ventricular fibrillation, long QT syndrome, early repolarization, non-ischemic cardiomyopathy, Brugada syndrome, dilated cardiomyopathy, hypertrophic cardiomyopathy. So it is enemy number one for the most common area that VF can be triggered from. Interestingly enough, very occasionally, but particularly in Brugada syndrome, RV outflow tract, particularly the epicardial RV outflow tract, can trigger VF. LV outflow tract very rarely, just regular ventricular myocardium, even occasionally epicardial ventricular myocardium in about 14% of patients, and the base of the papillary muscle, where you can record Purkinje-like potentials in about 10%, particularly in dilated cardiomyopathy. So this is the location of the PVC triggers. So I said the His-Purkinje system is integral in triggering and sustaining ventricular fibrillation. Let me share with you some of the data we have that talks about this. This is high density mapping of non-perfused VF during the first 10 minutes in 6K9 hearts. This work was done by Ray Eidecker and his team at UAB using both endocardial and epicardial mapping of the ventricular myocardium in these dogs. And what he was able to show is early on in the very beginning of VF, you see electrical excitation at multiple areas of the His-Purkinje system. And it is focal in many patients. The area of reentry, which you see as the triggering from the Purkinje fibers goes on, is related to, and you can see the sharp Purkinje spikes, is related to reentry at the Purkinje to myocardial interface. And then perpetuation of VF is due to more reentry, again, looking at the Purkinje to myocardial interface. Well, what other evidence do we have today that suggests the His-Purkinje system is really critical? These are 12 dog hearts which were treated with Lugol solution or Tyrode solution. And what these solutions do is they somewhat non-specifically destroy, the His-Purkinje system. So Lugol is shown in these lines with diamonds. The control animals are shown with circles. So here's what happens. You induce VF and you look at activations per second. In other words, how long the dog goes into fine VF after 6, 7, 8, 9, 10 minutes and the dog dies. If you destroy the His-Purkinje system using Lugols, again, a non-specific destroyer of the His-Purkinje system, you see VF is typically relatively short in duration and terminates. So if you ablate the entire His-Purkinje system, VF tends to not sustain or degenerate into sustained VF. Let's talk a little bit more about the His-Purkinje system because it's quite remarkable. It's only a tiny fraction of the entire left ventricular volume. It's only 1 to 2%. It is primarily located subendocardially, and it tends to be isolated from the myocardium. This is human Purkinje cells here, and these are mouse Purkinje cells, and you can see multiple fiber-like interconnections between the Purkinje cells themselves, sort of an interlacing network of fibers that communicates electrically between each other. Here you see the AV node, here you see the left bundle, and bifurcating into the different fascicles. The three fascicles we typically see anterior, posterior, septal, but distally into this vast network, even though it's not a high volume, but it's a vast network of Purkinje fibers that interconnect and interlace. This is another picture of the His-Purkinje system in humans from the left side. Again, here's the mid-septum. Here's AV conduction axis. Here you see the septal fascicle of the left bundle here. Here you see the posterior fascicle. This is the interventricular septum. And here you see the anterior fascicle. Here they are stained, and you can see again the multiple interdigitations among these fibers. Well, there are several unique things about the Purkinje fibers and network. I hope in those pictures I've shown you, you can appreciate how complex the architecture is of these Purkinje fibers. The intracellular calcium is cycling through these fibers, and you get reentry at the Purkinje myocardial junction. This shows the variation. This is 30 different patients. These are autopsy or necropsy studies of the conduction system done by Tawara over, I think, about 100 years ago now, a Japanese anatomist, and you can see the amazing variability of the His-Purkinje system from patient to patient, from person to person. You see how they are stacked here, and then they can interdigitate. These are the calcium fluxes, and it is an excellent substrate, as you can see here with the interdigitations among ventricular myocardium for reentry at the Purkinje fibers, myocardial junction. And there have been several studies where they've looked at this and been able to study reentry and this model of reentry at the Purkinje myocardial junction. We think even in ischemic cardiomyopathy patients who have VF, because what happens is the Purkinje fibers are somewhat spared from hypoxic damage, and so they're not killed. They just have this slow conduction, again setting up reentry between the Purkinje and myocardial junction. As I said, the Purkinje fibers are really critically important in idiopathic ventricular fibrillation and unexplained sudden cardiac death. This has been a project that people have worked on, particularly in Bordeaux, France, to try to understand what happens to these patients. They come from all over Europe to Bordeaux, where they go through a vast battery of tests, including MRI, but ultimately they are able to map PVCs in many patients. The problem with VF in general is that you are most able, most able, most able to get an excellent result, most able to do what you need to do when patients have frequent PVCs and you're capable of mapping them, as shown in this example with a patient here, a sinus beat, and then a PVC, and they just happen to be with this multipolar catheter. You can see from a sharp signal to a fractionated abnormal signal. These are several more examples of basically Purkinje fibers gone awry, triggering PVCs, and the PVCs trigger VF. The best time to map these patients is during electrical storm, or as soon as possible after an electrical storm, when their PVCs are frequent. So when I go up to the CCU and I see a patient with electrical storm, the first thing I ask them to do is hook the patient up to a 12-lead EKG. And when the patient starts having PVCs, run a 12-lead EKG. So we have some idea, some documentation of where the PVCs are coming from. And we map at least a couple of these patients on ECMO because these people can be extraordinarily sick when you're shocking them 10, 20 times during a mapping study. Careful mapping, not to bump the conduction branches and conceal into the distal Purkinje system. So let's go ahead and summarize and just talk about a couple other conditions. So treatment of recurrent VT-VF. So I'm talking not just about VF, but VT. What are the rules? Reduce catecholamines, withdraw inotropes, add beta blockers, correct hypoxia, deep sedation, correct potassium, magnesium, and calcium. Amiodarone is a standard drug we use, 150 milligram IV bolus, 1 milligram per minute infusion. You can repeat multiple boluses, but generally do not increase the infusion above 1 milligram per minute. Treat heart failure aggressively, early cardiac catheterization and PCI, primarily for recurrent VF. There's now very, very good data that for patients who have monomorphic ventricular tachycardia. So electrical storm with VF equals cardiac cath, true out an ischemic trigger. However, for monomorphic VT, cardiac catheterization really provides no benefit, no particularly useful information. And then if the patient has VF, you want to ablate the triggered PVC. They have monomorphic VT. The earlier you do catheter ablation, the better the patient does, both short and long term. This is an excellent review on electrical storm, published, written by one of our former fellows as first author, Guru Kawigli. It is required reading, I think, for our fellows who spend a fair amount of time in the coronary ICU. It talks about electrical storm and divides it into a triad. It's an excellent way to think about it. He suggests we think about the substrate, myocardial scar, and or what sort of arrhythmia syndrome does the patient have? Do they have long QT? Do they have Brugada? Autonomics, work on increased sympathetic tone and suppress parasympathetic system. You want to get rid of that. And then work on triggers, ischemia for VF, electrolyte metabolic derangements, toxins, drugs, heart failure, hypoxia. Now, of course, no review paper would be complete without an amazing flow diagram that Guru came up with. I'm not going to go through it step by step, but it is a sort of thing that is extraordinarily useful when you're in the CCU or when you're in the ICU taking care of these patients because it gives you the basic step-by-step approach to treating these patients. What's so critical is the appropriate patient gets the appropriate therapy. So for the first patient I showed you today, what is critical is autonomic modulation with stellate ganglionic blockade or anesthesia. Device programming for ATP so a patient doesn't have to get shocked all the time. ECMO, LVAD. In patients, you may need that to support them when you take them to the EP lab for ablation. Now, here's an example of what is a typical EKG finding. A short, long, short sequence followed by polymorphic VT or just a long, short sequence. Here's another one, polymorphic VT, long, short, coupled with a long QT interval, long, short, long coupling of a PVC at the end of a really prolonged repolarization. Again, long, short. This particular long, short pattern is typical for torsade de pointe, often drug-induced. The treatment of torsade de pointe, I want to remind everyone, is different from the treatment of electrical storm due to recurrent VF. Torsade de pointe has a typical EKG morphology, those long, short intervals with massively prolonged QT intervals. The treatment is intravenous magnesium, 2-gram bolus, and you can give up to 14 grams of magnesium in 24 hours. IV lidocaine plus minus may have some role. Increase heart rate by pacing or isoproternol. Obviously, correct other electrolytes like K and calcium, and discontinue the cause of QT prolongation. Discontinue the cause of QT prolongation. That's a treatment of torsade de pointe. What about this patient? This is a 66-year-old admitted with syncope. How are you going to treat this one? Amio bolus, lidocaine bolus, magnesium, ICD implant or monitor. Well, this patient, you're just going to monitor them because why? Because this is pure artifact. Here's the real QRS. Here's another real QRS. Here's another real QRS. Another one, another one. Sort of miss one here, 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 here. Now, this patient came in with syncope. It doesn't mean he doesn't have a serious arrhythmia. It just means this one, which he had at night when he was brushing his teeth, is not the thing that caused him to have syncope. So you have to be on your game when you see these people. What about this patient? This is a 32-year-old who came to our emergency room with near syncope. His blood pressure was 112 over 66. This is VCU emergency room, real stuff, real EKG. You can tell I had to change the color from red to black. You know, that's my pet peeve is EKGs that have red on white. But here we have black on white finally. And you can see this. So what's the next step? Pre-excited AFib. Don't give AV nodal blockers. This is what happened. So this is from the VCU emergency room. It's from a long time ago, but how often in your lifetime have you seen a patient present with pre-excited AFib? Remember, fat, broad, and irregular. Fat QRSs, broad, upstroke, irregular. How often have you seen a continuous strip showing AFib with the rapid ventricular response degenerate to VF? AF to VF, what did they do? They gave him IV cardizem in VCU emergency room. Acute treatment of pre-excited tachycardia is WPW. It used to be percanamide. Percanamide's almost impossible to get. It's now ibutylide, 1 milligram over 10 minutes, can repeat again in 10 minutes. Avoid DIG, verapamil, diltiazem, metoprolol. Avoid amiodarone. You're just going to mess it up for us 2 days later. Cardioversion if unstable, and then ablation. So I want to end and give you plenty of time for questions with some lessons I've learned over my many years of VCU. Make sure at the end of the day, you leave yourself time to think and talk with your mentors and colleagues here and across your specialty. VCU is a special place. There are lots of smart people. Find time to talk with them. Don't be afraid to take chances and try something outside your area of expertise. Spend plenty of time reading and thinking. You won't get that time when you're in practice. There's nothing more rewarding and exciting than translating basic research into clinical trials, learning new things, and challenging your brain. That's why you're here at VCU. And finally, treasure your personal relationships, especially at this time of the year. They're critical to better human health and happiness. And with that, I want to thank my colleagues with whom none of this would be possible. Dr. Shepard, Dr. Crone, Dr. Conneru, Drs. Kalahasti, Dr. Mancad, Dr. Pauley, and we always remember Dr. Wood and Dr. Padala. Thank you very, very much. I'm be glad to answer any questions.
Well, thank you so much, Dr. Ellenbogen. That was a really fantastic overview. Again, we have the CME credit here, so if anybody wants to use that, please do so. I guess I'm going to be selfish and ask some questions myself, Dr. E. So in regards to His-Purkinje, the His-Purkinje system, its sort of predilection to perpetuation of VF. You know, in terms of my own reading, one of the things that keeps coming up is the idea of VF in, let's say, structurally normal or structurally abnormal hearts. And it would seem that a lot of the patients we treat who have these episodes of VF, like the very first case that you showed us, you know, they don't necessarily have structurally abnormal hearts, at least not in ways that we can measure. I was wondering what sort of your assessment is of that. Is there actually truly something pathologically different about these His-Purkinje systems in patients who have idiopathic VF and early repole?
Well, I think the best model we have to study that is Brugada syndrome, right? Because these people have PVC triggered VF, or some of them have PVC triggered VF. The ones that have PVC triggered VF have been studied. Some small percentage of patients with PVC triggered VF, and it varies from patients to patient group to patient, have abnormal MRIs. Now, I would leave this field to people who are far more knowledgeable about MRIs. It's hard to know whether they're real abnormalities that are associated with electrophysiologic abnormalities or just when you peer through a microscope at anything, you find imperfections. However, even in patients who have absolutely stone cold normal MRIs, there are electrical abnormalities that tend to be clustered in one little area. So I think these people probably primarily have electrical disease that is not associated with structural abnormalities. Now, it's terribly different if you talk about mitral valve prolapse and PVC-induced VF, because with mitral valve prolapse, many of those people have structural abnormalities that are correlated with, the fact that they have PVC-induced VF. So even something like mitral valve prolapse, where there's an electrical substrate that's abnormal, that particular disease syndrome seems to be associated with a structural anatomic abnormality. But long QT and early repolarization and Brugada rarely have structural abnormalities, even with MRI. But again, I don't know how good the MRIs are. I don't know if they're on 3T magnets. I don't know if, Dr. Hunley or somebody like that is reading the MRIs. So it's just hard to know for sure.
Okay, yeah, because I think, well, certainly some of the data that the Bordeaux group is publishing, and I think Yoram Rudy and Cohen Ruben Coronel, they're really suggesting that there's like a microstructural abnormality, at least in Brugada patients, in the subepicardium and the RV outflow.
In some of those patients, for sure.
Yeah. Yeah. There's probably an overlap, and it does seem like maybe there's a final common pathway. Perhaps there's multiple different pathologies, and they all kind of lead to his Purkinje abnormalities. I won't take up too much more time then. There's a question from Dr. Hunley here. So he says, good morning, and thank you for your presentation and all that you do for our community and health system. Have a quick question. How is the advent of fibrosis imaging with MR or CT helped you in the assessment of patients with right or left ventricular arrhythmia? And somewhat related, have you found any particular aspect of atrial imaging that has been helpful in the assessment of atrial arrhythmia?
So let me do the easier one first. The question about atrial arrhythmia. I think that is a work in progress. And that has been somewhat limited by the fact that, at least in the early period of time when atrial fibrosis was being reported, there were labs that could not reproduce those results. So I think that whole area is in flux and somewhat completely dependent upon the skills of your imaging group. And um, I think I hope that's one area I'll learn more about in the next year or two or three, whatever, um, as we get programs that could better look at fibrosis in the atrium. And there are many complicating factors related to that. So I'll leave that one alone. The ability to do imaging of the ventricle, however, has more than any, there are really two developments that have revolutionized, made VT ablation so much more successful and so fascinating, both as an intellectual problem, but also getting a practical solution that helps patients. One is high density mapping, which we have multiple systems now that can do that, and we're becoming better and better at understanding maps of VT with high density mapping and the ability to get into the epicardium of the ventricle and record from that. We're not perfect yet because we can't record intramurally, see what's going on intramurally, but we're so much better off than we were 5 years ago before we had high density mapping. And the second thing, probably equally, maybe even more important, has been imaging and imaging and imaging. Actually, if there are four things, the first three are imaging and the fourth one's high density mapping. Imaging, and we're still learning a lot about imaging. And we're learning, and if you look at people who are doing the leading work in this area, they're doing it because they're working with imaging. And that's one advantage we have over everyone else who's doing VT ablation, in the community, is that we have amazing imaging and we can talk to our imagers, but The areas of fibrosis, 90% of the time, are related to the areas where VT circuits are critical to be able to understand where they are, to be able to map them there, and to be able to ablate them there. So fibrosis is a critical portion of that. There may be some role in ischemic cardiomyopathy for fatty metaplasia, and which can be elucidated with CT scanning. So CT scanning has some role, but the ability to look at fibrosis and to be able to quantitate it is transform the field. I mean, for example, we do radiation therapy of patients who are too sick to go to the EP lab. That's, that's all made possible by imaging and being able to see where the scar is that needs to be radiated. So it's been amazing, and we're looking forward to learning even more with combining imaging with mapping.
Excellent. Have another question. This is from Zachary Kitchen. Can you speak about the type and degree of side effects your patients may experience after cardiac sympathetic denervation?
Yeah. Well, I put everything in perspective after getting 50 shocks and being given up for dead. To be able to walk out of the hospital is pretty amazing. We had a young woman just a couple months ago who was 35 years old who was transferred here from one of the community hospitals, and they were like, we're not even sure it's worth transferring her because she's going to die. She got here. We immediately realized what she had. She had an idiopathic VF. We realized that within hours of her getting here, she had 80 shocks or something. And then we realized she needed a sympathectomy. She got cardiac sympathectomy. She eventually, 3 or 4 days later, got bilateral cardiac sympathectomy permanent. And she walked out of the hospital. She had two young kids. I mean, it is amazing, a powerful therapy. Yes, what's the price? Well, you could get Horner's syndrome. We haven't seen that. That's a complication. The main thing is hyperhidrosis on the lower half of your abdomen. So you sweat a lot on the lower half of your body, right? I guess that's a reasonable thing for not getting shocked by your defibrillator and being alive. But they're minor complaints related to sweating. That's mostly it.
Excellent. And here we have a comment from Bob Hirschberger. I appreciate your presentation, Dr. Ellenbogen. As a recent patient for PVCs, this provided me a better understanding of my condition and the action taken to resolve it.
Thanks, Bob.
Okay, I think that takes us pretty close to time. If nobody has any other questions, I'll conclude the grand rounds. Thank you so much, Dr. Ellenbogen. That was a really fascinating presentation.
Thanks, Jeff.
Thanks so
Everyone
much,
have a
Ken. Really
happy
appreciate it.
holiday, safe holiday.
Happy holiday.
Thanks, Ken.